Hello friends, today we are going to discuss the snake bite, snake venom. So we will first understand what is the snake venom exactly consists of. So each venom contains more than 100 different proteins, enzyme, non-enzymatic polypeptide toxin, and non-toxin proteins such as nerve growth factor. Non-protein ingredients include carbohydrate and metals, lipid, free amino acid, nucleosides, and biogenic amines such as serotonin and acetylcholine. Zinc metalloproteinases and metalloproteinases, hemorrhages. So we will see what exactly the role of this. So this is the enzyme which degrades the basement membrane components leading to endothelial cell damage, and it contributes to the spontaneous systemic bleeding. Now the next component, which is the procoagulant enzyme, it is the venom of the viper and some elapid and colubridae, which contains the serine proteases and other procoagulant enzyme that are thrombin-like, and it activates the factor 5, 10, and prothrombin and other clotting factors. These enzymes stimulates the blood clotting with formation of fibrin in bloodstream. Now we'll see what phospholipases are doing. So the phospholipase, it will damage the mitochondria, red blood cells, leukocytes, platelet, peripheral nerve endings, skeletal muscle, vascular endothelium, and other membrane, producing presynaptic neurotoxic activity, cardiotoxicity, and myotoxicity, necrosis, hypotension, hemolysis, hemorrhage, plasma leakage, opioid-like sedative effect, autopharmacological release of histamine and other otocoins. Now, the acetylcholine esterase, although found in most elapid venom, it may cause fasciculation. Now, hyaluronidase, it promotes the spread of venom through tissue by increased permeability, but can also contribute to the tissue damage. Now, the proteolytic enzyme and polypeptides, these are cardiotoxic, which increases the vascular permeability, causing edema, blistering, bruises, and necrosis at the site of bite. Now, the venom polypeptide toxin, that is neurotoxins. These are the postsynaptic neurotoxins such as alpha buongarotoxin and the cobrotoxin, which consist of 60 to 62 and 66 to 74 amino acids. They bind to the acetylcholine receptor at motor end. Presynaptic neurotoxin such as the beta buonogarotoxin and tepotoxin, which contains 120 to 140 amino acid and phospholipase A subunit. This will release the acetylcholine at nerve ending at neuromuscular junction and then damage the ending, which prevents the further release of the neurotransmitters. Now the pathophysiology of the human envenoming. So it consists of local envenoming, like it will manifest as swelling, bruising, which results from the increased vascular permeability attributed to the venom endopeptidase, metalloproteinases, hemorrhagens, membrane damaging polypeptide toxin, phospholipases, and endogenous autocoids released by venom such as histamine, serotonin, and kinin. Then it will result into hypotension and shock. After viper bite, leakage of plasma and blood into bitten limb and elsewhere, or massive gastrointestinal hemorrhage may cause hypovolemia. Vasodilation, especially of splanchnic vessels, and direct effect on myocardium may contribute to hypotension. Then this profound hypotension occurs within the minute. Bleeding and blood clotting disturbances. Snake venom affects the hemostasis in several ways. Procoagulant enzyme will activate the intravascular coagulation, producing consumptive coagulopathy and incoagulable blood. Potentially lethal spontaneous systemic bleeding is attributable to the venous hemorrhage. Now, next pathogenic mechanism is the complement activation. Complement activation affects the platelet, blood coagulation system, and other humoral mediators. Now, the neurotoxicity. Neurotoxic polypeptide and PLA2 of the snake venom causes paralysis by blocking transmission at neuromuscular junction. So patient with the paralysis of bulbar muscle may die of upper airway obstruction or aspiration, but the most common mode of death after neurotoxic envenoming is respiratory paralysis. Now the next is myotoxic. This phospholipase, myotoxin, and metalloproteinases are principally responsible. They are present in the venoms of the most species of the sea snakes. Many terrestrial Australian elapid and some species of the great and vipers, such as Sri Lankan Russell viper. Patients may die of bulbar and respiratory muscle weakness, acute hyperkalemia, and acute kidney injury. Now, the acute kidney injury. So we'll see what is the cause and what is the pattern of this acute kidney injury. So, wide range of renal histological changes has been described. Acute tubular necrosis is the most common, but the proliferative glomerulonephritis, interstitial nephritis, toxic mesangiolitis with platelet agglutination, fibrin deposition, and ischemic changes, distal tubular damage, suggesting direct venom nephrotoxicity attributable to the venom phospholipase and metalloproteins. And bilateral renal cortical necrosis with subsequent calcification are also reported. Snake venom-induced DIC may result in deposition of fibrin on vascular endothelium that has been activated by, for example, metalloproteinases producing microangiopathic hemolysis. Although clinical picture is the reminiscence of hemolytic uremic syndrome and TTP, there is no evidence of depleted Adams 13 level and therefore no justification for cryosuperintentant plasmapheresis. Now, generalized increase in the vascular permeability. Venom of some vipers, such as Russell and the Siamensis, cause the generalized increase in vascular permeability, resulting in pulmonary edema, serous effusion, conjunctival, periorbital, facial, retinal edema, bilateral parotid enlargement, albuminuria, and heme concentration. The likely cause is metalloprotease that damage the vascular endothelium. Now, the summary of signs and symptoms. So, till now we have seen the pathophysiology. Now we will see what signs and symptoms will cause because of this. So, the general signs are fear, anxiety, nausea, vomiting, malaise, abdominal pain, weakness, drowsiness, and prostration. The local symptoms and sign in the bitten part will be pharma, local pain, local bleeding, bruising, spread of local swelling, lymphangitis, lymph node enlargement, inflammation, local infection, abscess formation, and necrosis. So the cardiovascular manifestation, so mainly viper, it will produce the visual disturbance, dizziness, faintness, collapse, shock, hypotension, cardiac arrhythmia, myocardial damage. So the generalized increase in the capillary permeability will occur, that is capillary leak syndrome, is occur because of the Russell viper and the D. russellii in India, facial and conjunctival edema, bilateral parotid enlargement, pleural pericardial effusion, pulmonary edema, massive albuminuria, and heme concentration. Now, the bleeding and the clotting disorder is occur because of the viper. Traumatic bleeding from the recent wound and from the old partly healed wound, spontaneous systemic bleeding from gums, epistaxis bleeding into tear, intracranial hemorrhages, meningism from the subarachnoid hemorrhage, lateralizing sign or coma from cerebral hemorrhage, hemoptysis, hematemesis, rectal bleeding or melena, hematuria, vaginal bleeding, bleeding into mucosa, and the skin, which will manifest as Patechi, Pula, discoid hemorrhage, and ecchymosis. Now, the next manifestation will be cerebral arterial thrombosis, which occur because of the Russell's viper, and a thrombotic stroke confirmed by the angiography or imaging are increasingly recognized after envenoming by D. rusi in India, Sri Lanka, and Taiwan. Neurological manifestations are caused mainly because of elapate viper D. rusi, and it manifests as drowsiness, paresthesia, abnormalities of taste and smell, heavy eyelid, ptosis, external ophthalmoplegia, paralysis of facial muscle and other muscles innervated by cranial nerve, nasal voice, or aphonia. Regurgitation through nose and difficulty in swallowing, secretion, respiratory, and general flaccid paralysis. Now, the skeletal muscle breakdown is occur because of the sea snake, some crate species, generalized pain, and it manifests as generalized pain, stiffness, tenderness of muscle, pain on passive stretching, trismus, myoglobinuria, hyperkalemia, cardiac arrest, and acute kidney injury. Now, the renal pain, loin pain, hematuria, hemoglobinuria, myoglobinuria, oliguria, anuria, and distal symptoms and signs of acute kidney injury and urine. Endocrine features are manifest as acute pituitary adrenal insufficiency from infarction of the anterior pituitary. Now, the acute phase will manifest as shock, hypoglycemia, and in chronic phase there will be weakness, loss of secondary sexual hair, loss of libido, amenorrhea, testicular atrophy, and hypothyroidism. Hyponatremia implying natriuretic hormone-like activity in the brain. Now, so based on the above symptoms, the clinical syndrome which occur into the snake bite is divided into 5 types. So, syndrome 1 will consist of local envenoming plus bleeding and clotting, which occurs because of the viper. Then, syndrome 2 consists of local envenoming like swelling, bleeding, clotting, disturbance, shock or acute kidney injury, which occurs into the Russell viper with conjunctival edema. Acute adrenal insufficiencies occur into the Russell viper snake. External ophthalmoplegia, facial paralysis, dark brown urine is occur into the Russell viper snake bite. Syndrome 3 occur is consist of local envenoming with paralysis, which occur because of the cobra and king cobra. Then syndrome 4 is consist of paralysis with minimal or low local envenoming. Bitten on the land, it occurs when patient is sleeping on the land while sleeping on the ground without abdominal pain, and it occurs mainly in the crate. If there is a snake bite into the sea and some freshwater lakes, then it occurs because of the sea snake. Syndrome 5 is consists of paralysis with dark brown urine and acute kidney injury. It bitten on lands. It occurs because of the Russell viper. Bitten on land while sleeping indoor is occur because of the crate. Bitten in the sea and some freshwater is sea snake. Now, the symptoms and signs of the sea snake envenoming. Envenoming by the sea snake and the secret. The bite is usually painless and may not be noticed by wader or swimmer. Fangs and the other teeth may be left into the wound. There is minimal or no local swelling, and involvement of the local lymph node is unusual. Generalized rhabdomyolysis is dominant effect of envenoming by the snake, although patients without this feature have been described. Early symptoms include headache, thick feeling of tongue, thirst, sweating, and vomiting. Generalized aching, stiffness, tenderness of muscle become noticeable between 30 minutes and 3.5 hours after bite. Trismus is common. Passive stretching of muscle is painful. Later, there is progressive flaccid paralysis starting with ptosis, as in the other neurotoxic envenomics. Patient remain conscious until respiratory muscles are sufficiently affected to cause respiratory failure. Myoglobinemia and myoglobinuria develop 3 to 8 hours after bite. There are suspected when serum and plasma appears brownish and the urine dark reddish brown, that is Coca-Cola color. Bedside stick test will appear positive for hemoglobin and blood in the urine containing myoglobinuria. Myoglobin and potassium released from the damaged skeletal muscle may contribute to acute kidney injury, while hyperkalemia developing within 6 to 12 hours of the bite may precipitate cardiac arrest. Symptom and site of the cobra spit ophthalmia, that is eye injury from the spitting cobras. Spat venom enters into the eyes, there is immediate and the persistent intense burning, stinging pain followed by the profuse watering of the eyes with production of whitish discharge, congested conjunctiva, spasm and swelling of the eyelid, photophobia, clouding of vision and temporary blindness. Corneal ulceration, permanent corneal scarring, and secondary endophthalmitis are recognized complications of African spitting cobra venom but have not been described in Asia. Now, long-term complications of snake bite. At the site of the bite, there is a loss of tissue may result from the sloughing and surgical debridement of necrotic areas or amputation. There will be the chronic ulceration, infection, osteomyelitis, and arthritis, causing severe physical disability. Malignant transformation may occur into the skin ulcer after a number of years. That is Marjolini's ulcer. Chronic kidney disease may occur after bilateral cortical necrosis, which occur into the case of Russell viper and humpnose spit viper bites. Chronic panhypopituitarism and diabetes insipidus after Russell viper bite occurs into the India and Sri Lanka, most commonly in Myanmar. Chronic neurological deficit seen into the patient who survive intracranial hemorrhage and thrombosis. Abnormalities of electrophysiological test can persist over 12 months after following elapid bites in Sri Lanka. Delayed psychological morbidity has been reported 1 to 4 years after snakebite envenoming in Sri Lanka. Depression and anxiety, impaired functioning, post traumatic stress disorder, unexplained residual physical disability were reported. Chronic musculoskeletal disability have been reported following snake envenoming in Sri Lanka. The disability involving mostly lower limb and they range from swelling, muscle wasting, stiff joint, reduced muscle power, impaired balance, fixed deformities, chronic non-healing ulcer, and persisting lump to amputations. Now regarding management, recommended first aid. Reassurance, immobilization of the whole patient, especially their bitten limb, accelerated transport to the medical care, ideally in the recovery position. Unless a neurotoxic elapid bite can be excluded, applied pressure pad. Never use or recommended or condone tight tourniquet. Now treatment in dispensary. Rapid primary clinical assessment and resuscitation. Detailed clinical history, physical examination and species diagnosis. Simple test of blood coagulability, that is 20-minute whole blood clotting test. Then administration of antivenom, treatment of organ and system failure, treatment of bitten part, rehabilitation and the restoration of the function, advice at discharge from hospital and follow, and preventive health education towards reducing risk of future bite. Now, snake bite is the medical emergency. History, symptom, and sign must be obtained rapidly so that appropriate, urgent, and life-saving treatment can be given. Cardiopulmonary resuscitation may be needed, including administration of oxygen, establishment of intravenous access. Airway patency, respiratory movement, arterial pulse, and the level of consciousness must be checked immediately and record the vital sign. Glasgow Coma scale cannot be used to assess the level of consciousness of patient paralyzed by the neurotoxic venom. Now, the clinical situation in which snakebite victim might require urgent resuscitation. Profound hypotension and shock, terminal respiratory failure, respiratory distress, sudden deterioration, cardiac arrest, and late result of severe envenoming in someone arriving days, weeks after bite with severe bleeding, blood clotting disturbances, acute kidney injury, or septicemia complicating local necrosis. Now, regarding history, a precise history of circumstances of bite and the progression of local and systemic symptom and sign is very important. Now, examination of the bitten. The extent of swelling, which is usually also extent of tenderness to the palpitation. Lymph node draining the limb should be palpated and overlying ecchymosis. The bitten limb may be tensely edematous, cold, immobile, painful on passive movement, and with impalpable arterial pulses. These appearances may suggest intravascular thrombosis, which is exceptionally rare after snake bite, or compartment syndrome, which is uncommon. If possible, intracompartmental pressure should be measured, and the blood flow and patency of arteries and veins should be assessed. Early signs of necrosis include blistering, demarcated darkening or paleness of skin, loss of sensation, and smell of putrefaction. So this is the picture of the local signs of the environment. So the first picture is of the fang marks. Second picture is of the persistent local bleeding. Third picture is showing the blistering. Fourth picture is of the cobra bite. Uh, and the fifth picture is also suggestive of the blister. Now the general management, measure the blood pressure and heart rate. We have to measure the blood pressure in sitting and lying up position. Examine the skin and mucous membrane for evidence of patechi, purpura, discoid hemorrhage, ecchymosis, and conjunctiva for hemorrhage and chemosis, optic fundus for pretinal hemorrhage. Examine the gingival sulci throughout using the torch and spatula or tongue depression, as this may show the earliest evidence of spontaneous systemic bleeding. It is the very valuable sign. Then examine the nose for epistaxis. Abdominal tenderness may suggest gastrointestinal or retroperitoneal bleeding. Loin pain and tenderness suggest the acute renal ischemia, which occur because of the Russell's viper bite. Subarachnoid hemorrhage is suggested by the neck stiffness. Intracranial hemorrhage is suggested by lateralizing neurological signs. Asymmetric pupil, convulsions, and impaired consciousness. The neurotoxic envenom. Bulbar respiratory paralysis. To exclude early neurotoxic envenoming, ask the patient to look up and observe whether the upper lid is retractable fully. Ask about diplopia, test the eye movement for evidence of early external ophthalmoplegia. Check the size and the reaction of the pupils. Ask the patient to open their mouth wide and protrude their tongue. Early restriction in the mouth opening may indicate trismus, or more often paralysis of pterygoid muscles. Check other muscles innervated by the cranial nerves, like facial muscle, tongue, and gag reflex. The muscle flexing the tongue may be paralyzed, giving the broken neck sign. Then paradoxical respiration indicates the diaphragm is still contracting, but that intercostal muscle and accessory muscles of inspiration are paralyzed. Where possible, serial objective measures of ventilatory capacity are very useful. Use peak flow meter, spirometer, to measure FEV1 and FEC, or ask the patient to blow into the tube of sphygmometer to record the maximum expiratory pressure, or the use of single breath counting test. Single breath counting measures how far the patient can count at two numbers per second in normal speaking voice after taking maximal inhalation. A finger oximetry will detect the decreased arterial oxygen saturation. Remember that provided their lungs are adequately ventilated, patients with profound generalized flaccid paralysis from neurotoxic envenoming are fully conscious. Conventional test of brain death can prove misleading. Test the tone and the power of the limb muscle and the superficial and deep tendon reflexes. Look for lateralizing signs which are suggestive of intracranial hemorrhage and thrombosis. Observe involuntary movements such as fasciculations and myokalemia, and writing chorioathetotic movements suggesting hypoglycemia. Now generalized rhabdomyolysis. In victim of envenoming by sea snake, some species of the krait, some Australian elapid and Russell viper in Sri Lanka, South India, mussels, um, especially of neck, trunk, proximal part of limb, may become tender and painful on active and passive movement and later become paralysis. In sea snakebite envenoming, there is pseudotrismus that can be overcome by sustained pressure on the lower jaw. Myoglobinuria may be evident 3 hours after the bite. Now, regarding examination of the pregnant female, potential complication of envenoming in pregnancy include antepartum postpartum hemorrhage indicated by vaginal bleeding, premature labor, abortion, stillbirth, fetal distress, and intrauterine fetal death. If possible, uterine contraction and fetal heart rate should be monitored continuously. Fetal distress may be signaled by fetal bradycardia, tachycardia, late deceleration after each uterine contraction. If there is vaginal bleeding or need of imminent surgery, correction of antihemostatic abnormality after antivenom treatment should be accelerated using blood product. Lactating females should be encouraged to continue breastfeeding. So the first picture is suggestive of the examination for ptosis in patient with neurotoxic envenoming. This is usually the earliest sign of the neurotoxic envenom. Then the second picture is a broken neck sign in child envenomated by krait. Then the third picture is the examination for ability to open mouth and protrude tongue in patient with the neurotoxic envenom. Then this picture is suggestive of the generalized flaccid paralysis in patient envenomed by common krait, but the patient was fully conscious and was able to communicate by flexing his index finger. Now, regarding investigation and lab test, 20-minute whole blood clotting test. It is a simple and informative bedside test requiring only new, clean, dry and ordinary glass tube, bottle vial and syringe. The positive result indicates severe consumption coagulopathy and need for immediate antivenom treatment. False positive 20-minute WBCT result from the use of plastic, polystyrene, polypropylene rather than ordinary glass. A glass cleaned with a detergent, soap, washing fluid that destroy the surface activation of the blood coagulation. If new glass tube is not available, reuse the ordinary glass vessel. Wash with the normal 0.9% saline for intravenous infusion without detergent and other cleaning agent dried in hot air. False negative WBCT may occur in patients with mild degree of coagulopathy. So every effort should be made to eliminate false positive result by ensuring that ordinary glass is used, that recycled glass vessels are not cleaned with detergent and other cleansing fluid, and that normal controlled blood is used for comparison in cases where WBCT result is inconsistent with patient's clinical condition. Other more sensitive lab tests of blood coagulation. More sensitive lab tests that are rapid and relatively simple to perform are plasma prothrombin time or activated partial thromboplastin time. Measurement of fibrin related antigen, also known as fibrin degradation product, or the international normalized ratio, is the patient's PT divided by lab control PT. Abnormal INR results indicating coagulopathy, that is 1.2 or above. Point of care device for measuring INR and D dimer are expensive and unreliable in snakebite victims. Measurement of plasma concentration of fibrinogen and other individual clotting factor are more demanding in time and lab skills. Thromboelastography and thromboelastometry have been suggested as simple bedside method for assessing coagulopathy in snakebite victim, but the equipment is expensive. Analysis of take tracing provide the measure of time to initiation of clotting, speed of clot formation, clot strength that reflect the coagulation factor activity, fibrinolysis, and platelet function. Hemoglobin concentration, WBC count, platelet counts, and blood. Fragmented red cells. In blood film, we can see the fragmented red cells, that is helmet cell and schistocytes, where there is microangiopathic hemolysis and thrombotic microangiopathy. Hemolytic uremic syndrome consists of persistent profound thrombocytopenia, microangiopathic hemolytic anemia, and acute kidney injury. It is associated with envenoming by Russell viper, humpnose pit viper, and Australian elephant. Plasma or serum blood sample allowed to sediment spontaneously may be stained pinkish and brownish if there is gross hemoglobinemia and myoglobinemia. Then regarding biochemical abnormalities, plasma creatinine, urea, blood urea, nitrogen, potassium concentration are raised in acute kidney injury of Russell viper, hump-nosed pit viper, and snake venom. Aminotransferase and muscle enzymes will be elevated if there is severe local damage or particularly if there is generalized muscle damage. Mild hepatic dysfunction is reflected in slight increase in other serum enzymes. Bilirubin is elevated following massive extravasation of the blood. Early hyperkalemia may be seen following extensive rhabdomyolysis in sea snake. Bicarbonate will be low in metabolic acidosis. Hyponatremia is reported in the victim of great white in northern Vietnam. ABG and pH may show evidence of respiratory failure and acidemia. Desaturation, arterial oxygen saturation can be assessed non-invasively in patients with respiratory failure or shock using finger pulse oximeter. Regarding urine examination, urine should be tested by dipstick for blood and hemoglobin and for myoglobin. Red cell cast indicates glomerular bleeding. Massive proteinuria is the early sign of generalized increase in capillary permeability in Russell viper envenoming, an early indicator of acute kidney injury. Urine eosinophilia suggests the acute interstitial nephritis, but this can be confirmed only by the renal biopsy. Now, other investigations are radiography, ultrasound, echocardiography, and imaging, like CT and MRI to detect the bleed and infarct in the brain. Pituitary shrinkage in case of chronic panhypopituitarism. Unexplained hemorrhagic and demyelinating leukoencephalopathies after Russell viper bite in India. Then regarding ECG abnormality reported in the sea snake victim, including tachyarrhythmia, sinus bradycardia, STT wave changes, varying degree of AV block, and evidence of hypercapnia. Shock may induce myocardial ischemia and infarction in patient with diseased coronary arteries. Then regarding antivenom treatment. Antivenom is only specific antidote to the snake venom. The most important decision in managing snakebite victim is whether or not they need antivenom. It is the immunoglobulin purified from the plasma of horse and sheep, hyperimmunized with the venom of one or more snake species, medically the most important species in particular geographical area. Then the pre-specific neutralization of the venom of closely related species is possible but not certain. Indian polyvalent anti-snake venom serum is raised against the venom of their big four species like spectacled cobra, common krait, Russell viper, and saw-scalded viper. But other species now recognized as being important and are not covered. Thai Red Cross Society manufacturers neuropolyvalent snake antivenin covering the 4 elapid and the hematopolyvalent snake antivenin covering the 3 vipers. Now, regarding indication of antivenom should be given only to patients in whom its benefit are considered likely to exceed its risk. Since antivenom is relatively costly and often in limited supply, It should not be used indiscriminately, and the risk of reaction should always be taken into consideration. So, systemic envenoming includes hemostatic abnormalities, neurological sign, cardiovascular abnormality, acute kidney injury, myoglobinuria, local swelling, rapid extension of swelling, and development of enlarged lymph node. Inappropriate use of antivenom should be discouraged as they expose the patient who may need no treatment to the risk of antivenom reaction, and also there will be wastage of valuable and scarce food. Now, polyvalent versus monovalent antivenom. Polyvalent antivenom are preferred in many countries because of the difficulty in identifying species responsible for the bite. They can be as effective as monovalent. If the biting species is known, the ideal treatment may be with the monovalent antivenom, as this may be less expensive or may involve administration of lower dose of antivenom protein than with the polyvalent antivenom. However, immunization of the horse or sheep with the venom of severely related species of snake may produce enhanced antibody response to common antigen, making resulting polyvalent antivenom more than the less potent than the monovalent antivenom. Now, regarding dose of antivenom, the Indian National Snakebite Protocol and the previous edition of WHO guideline recommended immediate administration of 5 vials and recent consequences 4 to 6 vials in case of Achis carinatus. 10 vial for patient environmented by other species, with repeat dosing if the patient failed to improve to maximum of 20 vials. Then in clinical practice, the dose of antivenom used is very varied. In government hospital where antivenom is freely available, higher dose of antivenom are prescribed, often exceeding 20 vials. Children must be given exactly the same dose of antivenom as adult. Now, regarding the administration of antivenom, two methods of administration are recommended. That is intravenous push injection, which is reconstituted in the freeze-dried antivenom or neat liquid antivenom, is given by the slow intravenous injection. This method has the advantage that doctor, nurse, and dispenser given the antivenom must remain with the patient during the time when some early reaction may develop. It is also economical, saving the use of intravenous fluid, giving sets and can. And regarding intravenous infusion, reconstituted freeze-dried and neat liquid antivenom is diluted in about 5 ml of isotonic fluid per kg of body weight. That is about 250 ml of the isotonic saline or 5% dextrose in case of adult patient. It is infused at constant rate over the period of 30 to 60 minutes. Antivenom must never be given by intramuscular route if it could be given intravenously. It should never be administered into the gluteal region where absorption is exceptionally slow and there is high risk of sciatic nerve damage. So circumstances where intramuscular injection might be considered. At peripheral first aid station, before patient with obvious envenoming is put in ambulance for journey to hospital that may last several hours, an expedition exploring the remote area very far from the medical care, and when intraosseous access has proved impossible. Now, observation for response of the antidote. So general response will be patient feels better, nausea, vomiting disappears quickly. Now spontaneous systemic bleeding usually stops within the 15 to 30 minutes. Bleeding coagulability usually restored in 3 to 9 hours. In shockable patient, blood pressure may increase within the first 30 to 60 minutes and arrhythmia such as sinus bradycardia may resolve. Neurotoxic envenoming of postsynaptic type may begin to improve as early as 30 minutes after antivenom, but may take several hours. Active hemolysis and rhabdomyolysis may cease within the few hours and urine color return to normal. Now, criteria for giving more antivenom: persistent or recurrence blood incoagulability after 6 hours or of bleeding after 1 to 2 hours, or deteriorating neurotoxic or cardiovascular sign after 1 hour. How long after bite the antivenom be expected to be effective? Antivenom treatment should be given as soon as it is indicated. It may reverse systemic envenomy even when this has persisted for several days or in case of hemostatic abnormalities for 2 or more weeks. It is therefore appropriate to give antivenom as long as evidence of coagulopathy persists. Now regarding antivenom reaction, early anaphylactic reaction. It usually within minute or up to 180 minutes after starting antivenom. And patient begin to itch and develops urticaria, dry cough, fever, nausea, vomiting, abdominal colic, diarrhea, and tachycardia. The minority of these patients may develop severe life-threatening anaphylaxis, hypotension, bronchospasm, and anxiety. In most cases, these reactions are not truly allergic. So these are not Ig-mediated type 1 hypersensitivity reaction to horse or sleep protein, as there is no evidence of specific Ig. Complement activation by IgG aggregates or residual FCU fragment or direct stimulation of mast cell or basophil by antivenom protein are more likely mechanism for this reaction. Now, pyrogenic reaction usually develops 1 to 2 hours after treatment. Symptoms include shaking, chills, fever, vasodilatation, and falling blood pressure. Febrile convulsion may precipitate in the children. These reactions are caused by pyrogens contamination during the manufacturing process. These are commonly reported. Now, late reaction, that is serum sickness type, develop 1 to 12 days after treatment. Clinical features include fever, nausea, vomiting, diarrhea, itching, recurrent urticaria, arthralgia, myalgia, lymphadenopathy, periarticular swelling, mononeuritis multiplex, proteinuria with immune complex nephritis, and rarely encephalopathy. Patients who suffer reaction that are treated with antihistaminic and corticosteroid are less likely to develop late reactions. Now, prediction of antivenom reaction. Skin and conjunctival hypersensitivity test can detect Ig-mediated type 1 hypersensitivity to horse and sheep protein. However, large majority of early or late antivenom reaction result from direct dose-related complement activation rather than non-dose related Ig-mediated hypersensitivity. So these tests are not predictive. Since they may delay treatment and can themselves be sensitizing, these tests should not be used. Now the contraindication to antivenom. There is no absolute contraindication to antivenom treatment, but patients who have reacted to horse sheep serum in the past uh, and those with the strong history of atopic disease, they are at high risk of severe reaction and should therefore be given antivenom only if they have signs of systemic envenom. Subcutaneous epinephrine, that is adult dose of 0.25 mg of 0.1 solution, should be given just before antivenom treatment started, followed by intravenous anti-H1 histamine such as chloramphenicol. In asthmatic patient, prophylactic use of inhaled adrenergic beta-2 agonists such as salbutamol may prevent bronchospasm. Now, prevention of antivenom reaction. Adrenaline is the most effective treatment for anaphylactic reaction by reducing bronchospasm and capillary permeability. So, recommendation based on the result of the powerful and well-designed trial in Sri Lanka, routine use of prophylactic adrenaline is recommended before antivenom treatment, except in those older patients in whom there is evidence or suspicion of underlying cerebrovascular disease and when particular antivenom is used has proven low incidence of reaction. The adult dose of epinephrine is 0.25 ml of 0.1% solution, that is 0.25 mg, by subcutaneous injection. In children, it is 0.005 ml per kg body weight of 0.1% solution. Use of histamine, anti-H1 and anti-H2 blocker, corticosteroid, and rate of intravenous infusion of antivenom between 10 to 120 minutes. It do not affect the incidence and severity of early antivenom reaction. Now the treatment of antivenom reaction. Early anaphylactic antivenom reaction. Epinephrine is given intramuscularly in initial dose, that is 0.5 mg for adults and 0.01 mg per kg body weight for children. Because severe life-threatening anaphylaxis can evolve so rapidly, epinephrine should be given at the very first sign of reaction, even when only few spots of urticaria have appeared, and at the start of itching, tachycardia, and restlessness. The dose can be repeated every 5 to 10 minutes if reaction persists or symptoms become worse. Adrenaline has proven safe in pregnant female whose anaphylaxis can induce abortion. Additional treatment. After epinephrine, the patient with bronchospasm should be given inhaled short-acting beta agonist bronchodilator such as salbutamol or terbutaline, ideally by oxygen, or antihistamine. Anti-H1 blocker can be given such as chloramphenicol maleate. Intravenous hydrocortisone, that is 100 and adult 100 mg, and in children 2 mg per kg of body weight can be given, but it is unlikely to act for several hours. Corticosteroids do not reduce the risk of recurrence. Now, anaphylaxis, which is unresponsive to the intravenous epinephrine. Patients who remain shocked and hypotensive should be laid supine with their leg elevated and given intravenous volume replacement with 0.9% saline. Intravenous epinephrine infusion should be considered in adult dose, that is 1 mg of 0.1% solution in 250 ml of 5% dextrose and 0.9% saline. Infused at 1 to 4 microgram per kg minute and increased to maximum of 10 microgram per minute. Patient who remain hypotensive we can give vasopressor agents such as dopamine. Patient who remain dyspneic, bronchospasm and angioedema should be given propped up position at 45 degree, given supplemental oxygen by any available route together with optimal nebulized and inhaled or parenteral bronchodilator. Now the pyrogenic reaction. The patient must be cooled physically and given the antipyrete. Intravenous fluid should be given to correct hypovolemia. Patient who exhibit features of anaphylaxis should be given adrenaline as well. Now regarding late reaction may respond to 5-day course of oral antihistamine. Patient who fail to respond within 24 to 48 hours should be given 5-day course of prednisone. Now the doses: chloramphenicol, adult 2 mg 6 hourly and children 0.25 mg per kg per day in divided doses. Prednisolone dose: adult is 5 mg 6 hourly, children 0.75 mg per kg per day in divided doses for 5 to 7 days. Now this is picture 1 is the representative of early anaphylactic reaction to antivenom, that is urticaria and pruritus of the trunk. Then it is the picture 2 is representative of the angioedema of the face, tongue, gum, throat, and neck, and upper airway. When no appropriate antivenom is available, then patient must be treated conservatively. For respiratory paralysis, try as anticholinesterase, but without delay assisted ventilation. Hemostatic abnormalities: rest in bed to avoid trauma and transfuse cryoprecipitate, fresh frozen plasma, fresh blood products, and platelet. Shock and myocardial damage, correct hypovolemia, consider vasopressor drug. In hypotension, bradycardia, treat with dry atropine. Acute kidney injury, conservative treatment or renal replacement therapy. Rhabdomyolysis, correct hypovolemia with intravenous fluid, acidosis with soda bicarbonate. Severe local envenoming, surgical intervention, prophylactic broad spectrum antimicrobial. Supportive and ancillary treatment, neurotoxic envenoming, indications for intubation. Now, indication for invasive ventilation, patient who despite receiving oxygen by mask, nasal catheter remain tachypneic, have paradoxical respiration, deteriorating ventilatory capacity, hypoxia, respiratory acidosis. Then sedate them appropriately with fentanyl and midazolam, morphine and lorazepam. Ensure adequate hydration, nutrition, physiotherapy, regular turning to prevent pressure areas, lung collapse, eye care, and safe weaning from ventilation. Trial of anticholinesterase. After making baseline observation, give atropine sulfate intravenously followed by intravenous neostigmine and observed for next 10 to 60 minutes for disappearance of ptosis and improved ventilatory capacity. Treat patients who respond convincingly with repeated neostigmine and atropine. Hypotension and shock primary causes are the primary hypotension and shock. The primary causes are anaphylaxis, vasodilatation, cardiotoxicity, and hypovolemia. And secondary causes are high antivenom reaction, respiratory failure, acute pituitary adrenal insufficiency, and septicemia. Major postural changes in blood pressure and passive leg raising tests to determine fluid responses. Control fluid therapy using jugular and central venous pressure, respiratory rate, and detection of crepitation. Selective vasoconstriction such as dopamine may be used. Acute pituitary and adrenal insufficiency may occur into the victim of Russell Viper bite. Hydrocortisone is the life-saving in these cases. Oliguria and AKI impending AKI is signaled by the abrupt reduction in the kidney function over 48 hours, decreasing no urine output and increasing serum create concentration, and there will be the uremic syndrome. So patients should be monitored for the other signs of uremic syndrome such as pulse rate, postural blood pressure, height of jugular venous pressure, respiratory rate, temperature, presence of creps and uh, fluid balance or daily. Most patients with AKI become oliguric and conservative management may tide the patient over, avoiding the need for renal replacement therapy. In patients with intravascular volume depletion, establish intravascular access, give cautious fluid challenge. Stop challenge immediately if pulmonary edema develops. If urine output does not improve, perform furosemide test, challenge test. If that fails to increase urine output, switch to conservative. Conservative management for AKI includes no further diuretic, restrict the fluid intake to previous day output, plus insensible loss, refer to the renal unit. Then normal protein diet, low potassium and low salt diet. Measure the serum and plasma urea, creatinine, electrolytes daily. Examine ECG for evidence of hyperkalemia. If there is severe acidosis, correct with soda bile. Renal replacement therapy, if indicated, in patients with AKI associated with thrombotic microangiopathy, there is no evidence for plasmapheresis using cryosupernatant. In patients with myoglobinuria and hemoglobinuria, correct hypovolemia, maintain urine output 200 to 300 ml per hour, correct severe acidosis with bicarbonate, promote alkalinized diuresis, and continuing until creatinine kinase level less than 5,000. Diuretic phase of AKI, some patient may develop persistent polyuria of 5 to 10 liter per 24 hour and may become volume and electrolyte depleted. So regarding CKD, oliguria and dialysis dependent for more than 4 weeks, demand referral to the nephrologist and consider renal biopsy. Hemostatic disturbances usually corrected by antivenom, but recurrent coagulopathy is possible. Exceptionally, in patients already treated with antivenom but who have persistent severe bleeding and require urgent surgery, restoration of coagulopathy can be accelerated with blood product. Now, the treatment of patent part, nurse painful swollen limb in most comfortable position, avoiding excessive elevation, leave blisters, aspirate abscess, and culture the pus. Necrotic tissue demands early surgical dependence. Primary and secondary infection involve the aerobic and anaerobic bacteria from snake's oral flora, and patients' skin and a sterile incision. Tetanus toxin booster and prompt antibiotic treatment of necrotic wound is recommended. Compartment syndrome is often misdiagnosed and fasciotomy is performed unnecessarily. Since classical signs of compartment syndrome are difficult to assess, direct measurement of intracompartmental pressure is mandatory and fasciotomy must not be attempted before hemostatic disturbances have been corrected by antibiotics. Now management of cobra spit ophthalmia. So first is irrigation of affected eye and the other mucous membrane with the liberal quantity of water. Medical treatment involves analgesia, exclusion of corneal abrasion, and application of prophylactic topical antibiotic. Rehabilitation, conventional physiotherapy, accelerate functional recovery of the bitten limb. Discharge assessment, discussion, encouragement, follow-up, warning sign about late serum sickness type reaction, and advice about reducing risk of future snake bite are important. Thank you.